Welcome to another explainer. Today, we're going to systematically dismantle some of the most persistent and frankly dangerous misunderstandings in metabolic medicine. Whether you're a medical student, a nursing professional, or just an eager learner trying to grasp the realities of this condition, it is absolutely vital that we replace clinical fiction with hardcore, evidence-based fact. Because here's the reality. Diabetes is one of the most misunderstood diseases. Let's bust 7 dangerous myths. All right, let's kick things off with myth number 1. You've definitely heard this one. Eating sugar causes diabetes. It sounds super logical on the surface, right? But metabolically speaking, it's completely inaccurate. To really get why, you have to look at the actual pathophysiology. There's a fundamental difference between the two primary mechanisms. Type 1 diabetes is an autoimmune disease. Your body's immune system literally attacks its own pancreatic beta cells, causing an absolute lack of insulin. Sugar has absolutely zero role in causing that. Now, contrast that with type 2, which is driven by insulin resistance paired with a relative insulin deficiency. The onset there is multifactorial. We're talking genetics interacting with obesity and a sedentary lifestyle, not simply sugar intake alone. Okay, moving to myth number 2. You will hear patients say, "I have diabetes, so I cannot eat carbohydrates at all." This total elimination mindset isn't just restrictive, it actually flies right in the face of modern clinical guidelines. What we actually use is a concept called medical nutrition therapy, or MNT. MNT doesn't advocate for zero carbohydrates. Instead, the standard of care involves carbohydrate counting. The goal here is to accurately match the administered insulin dose to the exact amount of carbs the patient takes in. It's an exercise in precision, not prohibition. So the clinical priority shifts from total elimination to smart selection. We tell patients to prioritize high fiber, complex carbohydrates, and strictly limit simple sugars. Why? Because that specific approach is incredibly effective at controlling postprandial or post-meal glucose spikes. Now, myth number 3 is a massive diagnostic trap. Only obese people get diabetes. If we just conflate high BMI universally with diabetes, we are going to miss diagnoses in leaner patients. Let's look at exactly why that happens. A perfect example of this is the South Asian phenotype, an essential concept for any clinician to know. Patients of South Asian descent, including Indians, very frequently develop type 2 diabetes at surprisingly low BMIs. This happens because of a highly specific metabolic profile. They tend to carry high visceral fat, that's the fat surrounding the organs, coupled with a naturally lower beta cell reserve. Their pancreas essentially taps out sooner, even if they look completely lean on the outside. Plus, the clinical reality is that type 1 patients typically present as normal weight or even underweight at diagnosis. And on the flip side, a lot of obese individuals will actually never develop diabetes. As long as their pancreatic beta cells can ramp up production and compensate for the insulin resistance, their blood glucose stays perfectly normal. So BMI is a risk factor, sure, but it's definitely not the whole picture. Let's look at myth number 4, which is this highly fatalistic idea that diabetes is purely hereditary. This implies that your genetics are an absolute destiny. But genetics really just set the stage. In type 1, simply having the genes isn't enough. It usually takes an environmental trigger, like a viral infection, to actually initiate that autoimmune destruction of the beta cells. And in type 2, that is completely multifactorial. Those genetic predispositions have to interact with environmental and lifestyle factors over time, things like aging, obesity, and physical inactivity. For the disease to actually manifest. All right, moving right along to myth 5. There are only 2 types of diabetes. Oversimplifying the disease like this severely limits our ability to treat it effectively. Diabetes is actually a huge, heterogeneous group of metabolic syndromes. It's way more than just type 1 and type 2. You've got gestational diabetes during pregnancy, MODY, or maturity onset diabetes of the young, which is monogenic and usually hits under age 25, LADA, or latent autoimmune diabetes in adults, often called type 1.5, neonatal diabetes, and even double diabetes, where features of type 1 and 2 overlap. Recognizing this entire spectrum is vital for accurate, targeted therapy. Next up is myth number 6, and this one carries a deeply unjust stigma. Needing insulin means you failed. We hear this from patients all the time, and it's our job to reframe this narrative immediately. Look, for type 1 patients, insulin is a mandatory, non-negotiable lifesaver. Their bodies produce zero insulin. Taking it is literally no different than needing oxygen to breathe. But what about type 2? Well, in type 2 diabetes, beta cell function progressively declines over time. That's just the natural trajectory of the disease for many people. Escalating therapy to include insulin is simply a necessary, logical, clinical step to protect the patient's organs. It has absolutely nothing to do with personal or moral failure, and we must communicate that clearly. Finally, we reach myth number 7, a really dangerous brand of clinical fatalism. Diabetes cannot be prevented or controlled. Let's look at the hard data. 60%. The landmark Diabetes Prevention Program, or DPP, proved that intensive lifestyle modification, specifically just a 5 to 7% body weight loss, combined with 150 minutes of moderate exercise a week, cuts the risk of developing type 2 diabetes by a staggering 60%. It is highly preventable. And for those who already have the disease, control is absolutely possible and profoundly impactful. We've talked about the DPP, but look at the DCCT, the Diabetes Control and Complications Trial. It definitively proved that intensive glycemic control massively reduces microvascular complications in type 1 diabetes. And the UKPDS, the UK Prospective Diabetes Study, confirmed the exact same reality for type 2. There is no lower threshold here. Every single incremental improvement in glycemic control saves tissue, saves organs, and saves lives. Understanding the pathophysiology, embracing the actual data, and rejecting the stigma is how we elevate patient care. I encourage you to take these evidence-based facts and apply them in your studies, your practice, and your daily conversations. Because in metabolic medicine, the stakes are uncompromising. So ask yourself, what other medical dogmas are you accepting today without questioning the evidence? Myths cost lives. Facts save them. This is Clinical Clarity, MD, Medicine Made Clear.